ready? So today we're going to talk about schizophrenia, one of my very favorite topics, mostly because it is a mental illness that has so many different facets to it. So I want to preface this before we really get into this to say to you guys that we talked a little bit about self-awareness at the very beginning of the semester and how important that is. Well, when taking care of a patient that has schizophrenia, it becomes even more important. So increasing our self-awareness when it comes to caring for patients with schizophrenia is truly critical in being able to provide effective care for them. So how do we do that? For one thing, we need to make sure that we're knowledgeable about these patients. We're knowledgeable about the different aspects of schizophrenia, the positive, the negative signs of schizophrenia, the medications that are included, but even more so, we need to make sure that we understand how we feel about it. How we feel about patients who suffer with schizophrenia. Are we frightened of them? Do we think that they're unsafe? What kind of issues do we have with them? That's really important. And it is probably one of the most important things when it comes to being able to care for them. So the very first thing that we want to talk about with schizophrenia is what we call the clinical course. So the different phases that someone that has schizophrenia goes through. The very first phase that they go through is called the prodromal period. During the prodromal period, there aren't any kinds of signs and symptoms that are occurring with that individual. Generally, this is going to occur usually in those early adolescent or even early adulthood phases. These individuals will probably start to withdraw. They will become more isolated, be reflected in their grades. But for the most part, the only people that are really going to notice big changes are probably going to be their family. Following the prodromal period is the actual acute illness stage. During this stage, now we are starting to see actual manifestations of schizophrenia itself. We'll start to see positive symptoms. We start to see negative symptoms. We start to see that these individuals are truly going to withdraw. Their overall perception of how things occur within their actual daily lives are going to be evident. Generally speaking, during the acute illness phase, these individuals more often than not will require hospitalization. They will require hospitalization in order to normalize those chemicals that are imbalanced within their brains, as well as to help to develop different coping mechanisms. Once they are truly stabilized, they reach what we call the stabilization period. During this stabilization period, these patients are going to truly go from being a patient to then becoming a client. There won't be any more positive symptoms, or those positive symptoms will be significantly diminished. The overall negative aspects of their illness will significantly improve as well. Understanding that for the most part, while these symptoms do go away, for many patients who suffer from schizophrenia, especially if it's chronic and it's been ongoing and was treated a little bit later, they don't ever truly go away for them. Once they have stabilized, we reach the recovery period. During the recovery period, these individuals will go from being an inpatient facility, generally speaking, to an outpatient or a community setting. Within the community setting, they may learn new life skills, especially if it's a newly diagnosed client with schizophrenia. These individuals may have to learn different skill sets. We find that patients who suffer from schizophrenia often do much better at more solitary type of work than they do with being in large groups of people. And last but not least, we need to consider that patients will also suffer relapses. I wish that this were the case, that they never suffered them, but that just isn't realistic to think. The fewer relapses that patients have, generally the better that they do throughout their lifespan. So that is the clinical course. I would make sure that I know those. The next thing that we want to discuss for a few minutes when it comes to patients who suffer from schizophrenia is the actual diagnostic criteria. So what are the things that we may see a patient do that will indicate to us that there is something going on with them? With schizophrenia, they're very specific. I'm going to cover them today for the first time, and you will hear them multiple times throughout the semester. Positive symptoms. The positive symptoms of schizophrenia include disorganized behaviors, hallucinations, and delusions. What this means is these things are going to be corrected generally through the use of medications. When these positive symptoms are present, an individual that has the diagnosis of schizophrenia is acutely ill. That means that they are presently in the midst of an exacerbation. Okay, so positive symptoms. Excessive or distorted thoughts and perceptions are what is occurring with these individuals. They will have disorganized behavior. They will have disorganized thoughts, which we will talk more about in just a minute. The delusions and the hallucinations. Delusions are false beliefs about something, despite the fact that there may be evidence to the contrary. Even if there is evidence that shows that whatever their belief is false, they're not going to believe that that is the case because their perception is altered. Hallucinations, on the other hand, are sensory. So individuals that have hallucinations are going to hear things, they may see things, they may actually have what we call tactile hallucinations, so by touch. They may have olfactory, so smell. They are all related to the five senses, is how this works. Hallucinations, delusions, and disorganized behavior or disorganized thoughts. The negative symptoms are a little bit more tricky. The negative symptoms may still exist even after a patient's condition has actually stabilized. So the negative symptoms I often refer to as the 5 A's. Make it a little easier for you to remember this way. The first one is called apathy. Apathy simply means that this individual is really not going to care a whole lot about what's going on. They're going to be very apathetic, if you will. When things that are good happen, or when things that are bad happen, or when things that would normally affect us in an intense emotional way, individuals that are suffering from acute exacerbations of schizophrenia, and oftentimes even after that, may be very apathetic in general. They also suffer what we call a flat affect. So flat meaning, again, which is kind of related to the apathy, that they really won't experience truly any kind of a full effect of anything. When they talk, it will probably be very monotone. When you tell them something good or when you tell them something bad, they're truly going to have more of a constricted type of response to it. Anhedonia is another one. And some of these things will sound familiar to other conditions that we talk about, so they can overlap. Anhedonia simply means that they are unable to get pleasure out of things that they used to earlier in life or prior to them becoming sick. Anhedonia is also very common in depression. Avolition, or a motivational syndrome, is another one, which simply means that they lack the motivation or they lack the ability to be able to move forward. So oftentimes patients, family members will come in and they will say to me, my son's just lazy. He won't get a shower, he won't get out of the bed, he's not cleaning up his room, he's getting terrible grades, it's just because he's lazy. When in actuality what it is that he's truly suffering from avolition, which again, we see in depression. And then the last one, which is one that a lot of students forget, and we'll put it up here, is what we call alogia. Alogia is actually, the definition of it is actually poverty of speech. So in an individual that is suffering from schizophrenia, they oftentimes start to withdraw or they start to isolate themselves. And oftentimes when you ask them questions, their responses may be, instead of a full sentence or a detailed explanation, which we may be asking for, they may provide us with only a 1 or 2 word response. Where we can correct all of the positive symptoms that we talked about, oftentimes a lot of the 5 A's or the negative symptoms. And the way to remember this is with negative symptoms is that these are the ways that they're going to be affected functionally. So their function, it's going to be a negative impact on their overall daily abilities. For these individuals, we can correct the chemical imbalance, but this aspect oftentimes requires some therapy or better coping skills. It's not something that goes away. You may not see these exact negative symptoms in your book. However, these are the ones I want you to know. So make sure that you study these. You can look on page 339 in your book and it will give you more details about the positive and the negative symptoms that are associated with schizophrenia. Remember I said a few minutes ago that individuals that were acutely ill with schizophrenia, that they would have disorganized thinking or that they may have disorganized behaviors? Well, first let's talk for just a second about disorganized thinking. And I'm not going to cover every last one of these. So you are going to need to look in your book. You will also see this on your mental status exam. When you are interviewing your clients, you will see a lot of these terms, so it's important that you know them. Some of the terms that you may see may be echolalia. Echolalia means that the person who's suffering from schizophrenia will repeat everything that you say to them. It can be extremely annoying. Echopraxia or praxia is actually where they may imitate all your movements. So the same movements that you make, they will do the exact same thing. They will mimic you, in other words. Individuals that suffer from schizophrenia that are acutely ill, a lot of times will, when you are asking them questions, may do one of 2 things. They may do what we call be tangential in their responses, which means that I ask them a question and their response might start out to be what I'm asking them for, and then they just simply go off on a tangent and they never come back to the question at hand. Patients may also be what we call circumstantial. So their answer might be the answer that I'm asking for, but instead of giving me a direct answer, they go all the way around the world. But they do eventually come back. Tangential, they don't come back. Circumstantial, it just takes them a long time to get back to the topic at hand. Another thing that we see individuals who suffer from schizophrenia do sometimes is what we call clang association, where their response to whatever it is that you're talking to them about, all of their responses will rhyme. All of the words will actually rhyme. They also do what we call talking neologisms. Neologisms are words that they make up. They literally almost like have a language all of their own, but they make up words that have absolutely no meaning except to them. Patients that have acute exacerbations of schizophrenia also sometimes will talk in what we call word salad, where you ask them a question and it's almost like they just regurgitate a whole bunch of words that have nothing to do with each other. They don't make any kind of sense whatsoever, but we call that word salad, which is also, and some of these things that we're talking about are also things that we see in patients who suffer from dementia. You will see them kind of cross back and forth. Look in your book, make sure that you look at the different things that we talked about. I'm trying to think if there's anything else. Flight of ideas is also another one. Flight of ideas is where you ask them a question and again, they might start to answer you, but then they jump from one topic to the next and you can't get them to focus. It's almost like they have that attention deficit that we see sometimes in children, but we call that flight of ideas. There are a multitude of them. Make sure that you look at your mental status exam. If you have any questions about them, make sure and ask me about them in class because like I said, I'm not going to go over every last one. You should be able to look and to read in your book for all of that. What kind of behaviors do you think that we might see? Disorganized behaviors that are present in patients who are suffering from schizophrenia may include aggression. They might be very aggressive, especially if they are paranoid, which is also a type of behavior that we see in them. If they are paranoid or if they are suspicious of things that are going on around them, it may cause them to withdraw or it may cause them to be actually very aggressive. Something that we see rarely in patients who suffer from schizophrenia is called catatonia. In catatonia, they literally are in a catatonic state. So they might be awake with their eyes open, but they will sit in the same position for long periods of time. You're not going to see a verbal response from them. They don't move at all. Sometimes you will see what we call waxy flexibility, in that if I go up to a patient that is suffering from that, I can literally put them into a position and they will stay that way. Now, as a provider, I've never seen that. I've only ever seen pictures of that. So it isn't that common. I've been doing this for 10 years and I've never seen it. Patients who suffer from schizophrenia also have a lot of hypervigilance issues. This, of course, is related to the paranoia that oftentimes that they suffer. Again, not uncommon, but they're going to be super acutely aware of everything that's going on around them. So we've talked about positive and negative symptoms. We've talked about behaviors. Now I want to spend a couple minutes talking about the background, the pathophysiology, the epidemiology that's associated with schizophrenia. There is all kinds of debate as to whether or not that schizophrenia is truly genetic. Most individuals, most experts will tell you that it is. First-line descendants or first-line family members have a 10 times increased risk of developing schizophrenia. So in other words, as a mom, if I had a child and I suffered from schizophrenia, there's a 10 times more likelihood that my child would develop that as well. However, there is a much greater impact from environmental aspects, depending on what's going on within their environment. Remember that most mental health issues, most mental illnesses are a result of high levels of stress in which that individual's resilience that we've already talked about this semester isn't able to navigate through that particular problem. So they wind up having a break of some sort. Environments where there might be abuse that's going on or substance abuse, maybe that individual is having to care for his brothers and sisters, or that something, maybe there's even been a death, somebody that's important to them has passed away. We know that the environmental link actually has a much bigger impact really than genetics does. What about gender-wise? Generally speaking, men do have more severe cases of schizophrenia. They usually go untreated for longer periods of time, and the longer that you go without treatment, the more likely that you are to have a poor prognosis. So very unstable. They will have more relapses. Men actually suffer or are at risk for schizophrenia at a younger age than women are. The prime age for men is actually 17 through 25, and for women it is actually 25 through 35. So there is a little bit of difference in there. We don't generally see a lot of true development of schizophrenia after those particular ages sometimes, but it's not real common actually. Another thing to consider when we talk about the appearance of schizophrenia is comorbidities, health problems like diabetes, even obesity. These things actually, believe it or not, contribute to the development of schizophrenia because of the high levels of stress, as well as substance abuse. Moving on to the types of schizophrenia, there are actually several different types of schizophrenia. There are 5 types that I want you to be familiar with. So the first type of schizophrenia, the one that we see more often than not, is called paranoid schizophrenia. The prominent features of paranoid schizophrenia are going to be a preoccupation with hallucinations or with delusions. Most of the time, they're going to believe that they're being persecuted, or they're going to be what we call grandiose in nature. Usually, a delusion is linked with a hallucination. So they have false beliefs about something, and a lot of times it will manifest in a hallucination, like hearing those voices or seeing things that are not there. But oftentimes we see that they are actually linked together. The next type that we see is called disorganized type of schizophrenia. In disorganized, we see that their speech will be very disorganized. Their behaviors will be very disorganized, difficult to follow, that they will have those flight of ideas, that they will jump from one topic to the next. They will have very flat features, so their overall affect will have very little response. In disorganized schizophrenia, the individual will appear to be very unkept, a lot of times dirty. Their language will be difficult to follow. You will see inappropriate affect, and overall, their general appearance is just going to be out of the ordinary, so to speak. The hallucinations and the delusions that someone that suffers from disorganized schizophrenia are going to be very fragmented, so we don't see that link between the two like we do with someone that suffers from paranoid schizophrenia. So they're just very disjointed or disorganized, as we call it. Catatonic is another type of schizophrenia that we see, again, not very often. These individuals are going to suffer from extreme psychomotor retardation. So we're going to see, again, that's where we talk about the very limited actual movement that they have. We talked about the wavy flexibility. We did not talk about sometimes that they will have what we call purposeless movements. So you may actually see in them that they may have the swinging of their legs or the swinging of their arms, and that be the only thing that we see, but very purposeless in their response. It is the patients who suffer with catatonic type of schizophrenia that you will primarily see the echopraxia, the echolalia, even mutism, which is very common. We see a lot of that in individuals that suffer from this particular type of schizophrenia. Undifferentiated schizophrenia is the 4th type of schizophrenia that we want to talk about. In this, these individuals, while they are in the psychotic state, which means that they're experiencing hallucinations, delusions, and disorganized behaviors or thoughts, that's considered psychotic. They will experience those things, but they really will lack any other kind of symptoms that go along with it, which is why we call it undifferentiated. This is a more difficult type of schizophrenia to actually treat because we don't see a whole lot of real prominent type of signs and symptoms with it. This is a more difficult type of schizophrenia to actually treat because we don't see a whole lot of real prominent type of signs and symptoms with it. And the last type of schizophrenia that we want to touch base on is called residual schizophrenia. In residual schizophrenia, there has to be at least one documented episode of schizophrenia, but the positive symptoms have resolved, so the hallucinations, the delusions, the disorganized thoughts and behaviors have disappeared, but the negative symptoms are going to remain. So that apathy, that affect, that anhedonia, that avolition, and that alogia are still going to be present. In your PowerPoint, be sure to look at what we call the schizophrenia spectrum disorders. That's going to be important for you to know, but I'm not going to spend a lot of time going over them. I do want you to know that schizophreniform is actually what we call, or what we say schizophrenia is for the first 6 months. In order for a patient to get a diagnosis actually of being schizophrenic or having schizophrenia, they have to have both those positive and negative signs for at least a 6-month period. So someone that comes in and has been having these types of symptoms for the last 2 months is not going to automatically get a diagnosis of schizophrenia. We're going to say that they are schizophreniform. And some of those patients will actually resolve and may never have them again. But we have to, in order to give them that diagnosis, we have to see those signs and symptoms for 6 months continuously, not a month here and a month there. Okay. All right. Remember at the beginning of the semester, I said that we treat mental illness in a holistic manner. So we look at the biological aspect, we look at the psychological aspect, and we look at the psychosocial aspect. Well, schizophrenia is very much the same way. So we have to make sure that we look at it at all of those angles. So we're going to look at the genetic connection, or we're going to look at the environmental connection. We're going to look at pharmacological measures that we may have to do for those individuals. There are going to be certain what we call priority care type issues. And of course, the most important one is going to be safety for them. In this holistic treatment, we're going to include biological, psychological, so the actual chemical imbalance aspect of schizophrenia, as well as the psychosocial. The priority care issues for patients that suffer from schizophrenia are going to be doing suicide assessments. Individuals that suffer from schizophrenia, that's not generally the first thing that we worry about, usually is a result of impulsivity that they suffer from in this disease process. We want to make sure that we're looking at aggression, whether it is towards themselves or towards others. And incidentally, one of the things that I hear a lot from students is that they're afraid that someone that suffers from schizophrenia is going to hurt them. Please understand that most patients that suffer from schizophrenia are much more likely to hurt themselves than they are you. They are much more likely to turn on themselves internally, is how we refer to that. And of course, we're going to, for an individual who's suffering from an acute exacerbation of schizophrenia and for long-term management, we're going to be doing antipsychotic medications for them. Okay, here's one of the big aspects of schizophrenia. Often my students at the end of the semester, one of the things that I have on the final is a case study. And in the case study, one of the things that I ask you to tell me about of medications that you would use for a patient that has a particular condition. Many times in the past, I have used the example of a patient who is suffering from schizophrenia, and I asked them what type of medication that they would use. There are, as we studied earlier, we know that there are a couple different categories when it comes to antipsychotics. We have first-generation antipsychotics and we have second-generation antipsychotics. The first-generation antipsychotics are older. They're the ones that came out first. Haloperidol being one of them. Chlorpromazine or Thorazine is the other name, being another one of them. Are they effective? They are sometimes, but they have lots and lots of extrapyramidal side effects. So we are less likely to use the conventional or the first generation antipsychotics because there are so many side effects that are associated with them. But I find that a lot of times because haloperidol or Haldol is one that comes automatically to mind, that students like to use that as an example. It is a poor example, you guys. It is a poor example. Haldol tends to be one of the last things that I use for patients, especially if it is a young patient. The extrapyramidal symptoms, the increased risk for tardive dyskinesia, which is absolutely disfiguring for a patient, is such a great risk for someone, especially the younger that they are. So I try to avoid that. So in place of that, we try to use the atypical or the second generation antipsychotic. They have many fewer side effects. The main side effect of the newer antipsychotics is metabolic syndrome. So what is that? In review, increased what? Blood pressure, as well as increased blood sugar, which can result in metabolic side effects. These individuals oftentimes will have higher blood pressures. They will gain weight because for a lot of antipsychotic medications, increased appetite happens to be one of those side effects. So they gain weight, they become obese, they become diabetic, and these are a lot more prevalent in the newer antipsychotics. However, the newer antipsychotics actually control not just the positive symptoms, so those delusions, hallucinations, and disorganized thinking and behaviors. How many times have I said that already, you guys? That's going to be important. But it also controls those negative symptoms, which are much more difficult to be able to pinpoint and to be able to treat. So it controls all of these that we talked about earlier. The first generation or the typical medications do not do that. The only thing that they treat are those positive symptoms, so they will take those away. The other big thing that comes along with using atypicals versus conventional is that the conventional antipsychotics are very inexpensive. So when do I use them? I use them if the newer medications have not been effective, or if there is unfortunately an issue with being able to pay for them and maybe there are not patient assistance programs out there. But just so you know, most of the, especially the newer antipsychotics, they do have patient assistance programs. But ultimately for some patients, the older ones are just the ones that work. So conventional versus second generation. Just as effective, really, at least as far as the positive symptoms, but remember that with the newer ones, they're going to treat the negative symptoms as well. The older medications, the conventionals, are going to be much less expensive, as in under $20, whereas the newer ones, the atypicals, we are talking about thousands of dollars. So an individual that is getting an atypical antipsychotic, their medication for a month might cost $3,000 or $4,000. Not realistic for a lot of patients, especially that suffer from chronic mental illness. The other thing is that I said that you have increased risk for extrapyramidal symptoms, especially tardive dyskinesia with the first generation, as opposed to the metabolic effects that go along with the second generation. They both have their place, but generally we're going to use the newer ones as opposed to the older ones so that we can treat them more comprehensively, more holistically, really is the word. The part that is the most scary for students, and of course for providers like myself, is selecting the right antipsychotic. Earlier this semester, I gave you guys a handout that had all of the antipsychotics that I wanted you to know. What I didn't tell you were the things that separate them from other antipsychotics, the things that are important for you. So I want to go over those right now really quickly. Clozapine, or Clozaril, which is bar none the best antipsychotic that we have to treat schizophrenia, is also one of the antipsychotics that you will never see used as what we call a first-line treatment. As a matter of fact, the only time that we're going to use clozapine is after we have actually had failed trials of 2 other antipsychotics. So they've got to be put on 2 other antipsychotic medications. Neither one of them have worked, and then we will try the clozapine. The reason for this is that clozapine or Clozaril actually runs a higher risk for the development of what we call agranulocytosis. We have to do very regular monitoring of their blood levels to check that white blood cell count so that they don't get too low. This is a big thing. This can cause lots and lots of problems, even death. Clozaril, although it is extremely effective at treating both those positive and negative symptoms, has some pretty significant side effects that go with it. Additionally, it is also, along with Zyprexa, which we'll talk about in a second, is one of the bigger weight gainers. So patients who are taking this medication oftentimes really struggle with being able to keep their weight under control. Risperidone, or Risperdal, is another medication that we use. This is also an atypical or a second generation antipsychotic. I always remember this, or at least when I was studying for my boards, one of the ways that I remembered what Risperdal did, or what the big side effect was, is that you remember several years ago they had on TV a commercial that talked about the development of breast tissue in men. That was for Risperdal. So I always remember that Risperdal gives rise to a pair. So it can actually increase the size of the male breasts. And a lot of men, especially younger men, are not going to want to do that. What I mean by that is I can put them on it and it'll be effective, but if they start to develop gynecomastia, they're going to stop taking it. So you have to keep that in mind as well. The next one is olanzapine, or Zyprexa. Again, a very effective medication, but this is one that I try to avoid putting especially young women on. Olanzapine and Clozaril both run neck and neck as far as weight gainers, but Zyprexa is the one that has the biggest weight gain. Many women, especially if they're younger, are not going to take a medication that causes them to gain 50 pounds in a 6-month period. They will stop taking it. Now, interestingly enough, the older that they get, women my age, in their 50s or even in their 60s, if the Zyprexa works for them, they'll tell you that they don't care if they gain 50 or 60 pounds as long as it works for them. But that is not the case for someone who is younger, understandably. The last one that we want to touch on, and I don't know if I said this, I think I did, that as far as the atypicals or the second generation, Geodon or Ziprasidone. Ziprasidone is probably one of my favorite second generation antipsychotics because I just find that it works really well. It really, for a lot of patients, does what I call almost reset them. If they're really experiencing especially more aggressive type behaviors, it almost really just resets them. The big problem or the big concern with Geodon is that it increases the QTC interval. So you wouldn't use this for patients who has heart issues. So those are all the atypicals, the second generation, the newer ones. What about the typical or the conventional? Chlorpromazine or Thorazine is the very first one that came out. It actually came out in the 1950s. Individuals that take chlorpromazine or the Thorazine a lot of times develop what we call the Thorazine shuffle. They almost look like someone who has Parkinson's. So they will literally kind of shuffle along as they're walking. So we try to avoid that. It also really has a very sedating effect to it. So in older persons, this can be very problematic. Fluphenazine or Prolixin is another first generation antipsychotic that we use that there's not any big concerns, at least as far as adverse effects that go along with this, not any more than any of the others. And actually Prolixin really works pretty well if you have to use a first generation antipsychotic with our younger generation, actually. The last one, of course, is haloperidol or Haldol, which happens to be the one that almost everybody knows. It is also an older antipsychotic. I can put a patient on this and they can actually get this orally, or they can get it through an IM injection, as well as the Prolixin, by the way. This is also a good medication, but it has lots of side effects. Oftentimes I try to avoid putting patients on this. So in the event that you have a question on your next test or even on your final, Haldol is not a first-line treatment for schizophrenia. So when using antipsychotics, there are a couple of conditions that we want to make sure that we talk about really quickly. The first one being neuroleptic malignant syndrome, NMS is the other way that we refer to it. It is a life-threatening condition, and it does require immediate hospitalization of the individual that is suffering from it. These individuals will experience severe muscle rigidity. So they will have just extreme stiffness. You won't be able to move their joints at all. They will have very high temperatures, and I don't mean like 101 or 102. They'll develop like 104, 105 type of temperatures. The symptoms that they have will happen very, very quickly. So it would be very acute in nature. What do we give? Well, of course, we're going to stop the medication. We're going to give them IV fluids. And most of the time, in order to counteract it, we use the muscle relaxant dantrolene. So we will give them that in order to decrease that muscle rigidity that they're having. We're of course going to monitor their vital signs. We're going to treat the fever. We're going to do lab testing to make sure that they're not suffering from agranulocytosis. And of course, we're going to make sure that we are creating a safe environment for them, especially because of that rigidity. Another condition that individuals that take antipsychotics is called an anticholinergic crisis. In an anticholinergic crisis, this is also life-threatening. This is where they actually have an overdose or a sensitivity to drugs that have anticholinergic properties, which antipsychotics do. We also call this anticholinergic delirium. When you were in adult health last semester, you probably talked about some of those signs and symptoms. Remember when you talked about hot as a hare, blind as a bat, mad as a hatter, dry as a bone? Those are all those anticholinergic symptoms that individuals suffered from. And of course, this can actually occur to a really great degree, which causes that anticholinergic crisis. It's usually what we call self-limiting. So usually within a 3-day period, it generally resolves. How do we treat it? Of course, we stop the medication. That's the best way to stop it. We may actually have to pump their stomachs. We might do a gastric lavage. We might do charcoal activation. And then we always have to consider whether or not that this was an intentional diagnosis and the possibility of having to do additional treatment, especially therapeutic in nature. Okay. So as we bring this to a close, the last thing that we want to talk about is how do we prevent relapse in our patients that are suffering from schizophrenia? How are we going to keep them from stopping taking their medicine? So medication noncompliance. How are we going to address those kind of issues with them? There are programs, or what we call relapse prevention type programs, which actually combine not just medications, but the therapeutic aspect of it. I can't say enough how important it is that we use a combination of both medication as well as therapy. Medications have their place, but for long-term effective treatment, there has to be therapy in there. Patients have to be able to develop coping mechanisms. They may have to make changes in their overall daily life, including family in developing these plan of cares, and of course, including the patient is going to be instrumental. Without the cooperation of the patient themselves and giving them input in how to best care for them, the likelihood of them being compliant with whatever the plan of care is not very good. And their families are going to be important to us because they're be the ones that are going to be monitoring their medications, monitoring their behaviors. a lot of times they're going to be the ones that are going to see changes, or that they're going to see what we call decompensation in those patients, to where they may need to have an adjustment in their medication, or in some cases, if they've come off of their medications completely, they may require hospitalization. So families are really important, and they must be included in that as well. So the key to preventing relapse for patients is increasing their overall knowledge of their condition, of their medications, of the therapies and the coping mechanisms that are effective in treating their particular condition, getting their families on board so that they have a good support system, and in general, making sure that we're monitoring them. We are checking up on them. How is that going to be done? Generally, it's going to be done through the community. So making sure that either they have a personal physician that is doing this, or that they are making use of the services that are within our communities. And that is all about schizophrenia. We will talk more about this in class. Expect a quiz. We may have that, but without watching this, it was going to be very difficult for you to participate in class. And in order to be able to get everything that you need as far as schizophrenia is concerned, you're going to have to do both. All right, have a great day, and I will see you all next week.